And I've just pressed record as well so that we can share this with others that weren't able to make it. But without further ado, I will pass over to Dr. Maniyar.
Well, thank you very much, Gemma. Pleasure to be here. Thank you to Migraine Trust for this opportunity to speak to colleagues and people who are interested in headache. So this is a question and answer session. I thought I'll just show a couple of slides just to introduce myself. I'm a neurologist who is interested in headache. I'm interested in the clinical aspects of headache, diagnosis and treatment and management, of course. I'm also interested in research and understanding the pathophysiology of headache symptoms, light sensitivity in migraine. Why do people feel that? Why do people get nausea during migraine attacks? What is the origin of the migraine attacks? So we have done a lot of work on that essentially. I'm interested in understanding it. Of course, there's a lot more to understand. As far as my practice is concerned, I am based at Cleveland Clinic, London, which is a new hospital started in London. The outpatient facility is at close to Oxford Circus, and the main hospital will be starting next year, opposite Buckingham Palace. On the NHS, I'm affiliated to Barts Health, but that's mainly an honorary affiliation, mainly for academic purposes. So next slide, please. So we're talking about headache today, and headache is, I'm sure, all of you will agree, headache is a common problem. Certainly, whenever we have audited our neurology services in secondary care, invariably headache is the most common reason why patients are referred to see neurologists. Between 30 to 40% of patients, a lot of patients, a lot of higher percentage of patients. Yet, headache and migraine in particular is poorly diagnosed. We reckon about 15 to 20% of the population has got migraine. Many of these people never get a diagnosis of migraine, or they are wrongly diagnosed as sinusitis or cervical spondylosis or facial pain for dental reasons or ear problems. I've seen all kinds really. So the diagnosis is a problem. And the management is a problem as well. If you don't get a diagnosis right, you won't be managing them appropriately. Management problems are various really for headache and migraine. One is obviously the diagnosis issue we talked about, but also management itself, because a lot of the medications that we have, to be fair to patients really, a lot of those medications, we have to be very careful. It's not just that you diagnose a person with migraine, here is the triptan, here is the amitriptyline, thank you very much, bye-bye, see you later, or discharge. But what happens to amitriptyline? How many people stay on amitriptyline at 1 year? So very small percentage of patients really, because many of the patients will develop side effects and want to give up basically. That's the most common reason why people give up, because of lack of tolerability rather than effectiveness. So we need to be aware of that. You see, as doctors treating these patients, we need to be aware of that so that we take that into consideration. And therefore, we need a multi-pronged attack. So acute treatment, preventive treatment, medications, injections, nerve blocks, lifestyle, newer treatments. So all of that has to be utilized in a proper way and in a unique way really for the person ahead of you, so that the person is likely to engage and stay on the treatment long enough to, of course, enjoy the benefits of treatment and get treated successfully. So I thought I'll just say that at the start. I'm sure there will be a lot of questions. Whenever I speak to GPs, you guys, of course, ask a lot of relevant questions, very practical questions. And I thought we'll start off with questions, and that will give me an opportunity to open up and share with you my ideas about those particular issues in management of headache. So Q&A is open now.
Lovely, thank you, Dr. Maniyar. So as I said, for those that have joined us, you can either type your question into the chat box and we will go through them, or if you use the raise hand function on Zoom, we will come to you directly as well. I'm just going to kick off with one that was put in the chat box very quickly initially, and that is around the progress of the Diatons license.
Okay, so the Diatons, as you may have heard, so the Diatons have been approved for use by the FDA for some time now. Now, in Europe, for some reason, and I'm not sure why. For some reason, they haven't. I mean, certainly nobody has approached me from the Diatons group. I mean, I'm not the biggest guy in headache. I don't mean that, but all my colleagues as well really haven't been approached by the Diatons manufacturers in terms of introduction of their medicine in Europe and certainly in UK in particular. I know the EMA is certainly looking at it. Certainly NICE hasn't published anything on Diatons as yet, essentially, as far as I'm aware. Diatons will be obviously useful. I don't think they're going to be more effective than triptans. But of course, as many of you will be aware, Diatons do not have this action on the blood vessels, so they don't cause vasospasm. So they are safer. They're safer to use than triptans, essentially. And you can use them in people where you might not want to use triptans. So for example, somebody with a history of diabetes and the blood pressure is not well controlled, so there are risk factors for the use of triptans. In those groups, you may want to use Diatons, essentially lasmitidine, for example. Yeah, that's what my knowledge is on that at this point.
Lovely, thank you. And Susanna, I think you were first with your hand up.
Yes, hello. I've just been discharged from hospital, having been admitted with an internal bleed, which they thought was due to taking aspirin, because I've been taking aspirin for migraine onset, as advised by the Migraine Trust, and it really, really helped. But I'm on propranolol daily, and I don't think it was working that well, because I was taking a fair amount of aspirin, which seems to have caused an internal bleed. And so I went to see the GP this morning, and they said, don't take any more aspirin again, because you have internal damage from it. And they said that still propranolol is the best treatment, and they suggested, is it triptans instead of aspirin? I just wanted to, as you're an expert, I just wanted to check what you think about that.
No, sure. Thank you, Susan, for the question. So yes, aspirin, the amount of aspirin that you need to use for acute treatment of migraine is quite large. So typically 900 milligrams, so 3 tablets of 10 milligrams, although some people use just a single tablet, some people use 2 tablets. But the recommended dose for successful acute treatment is 900 milligrams, which is a rather large dose. And sometimes that can cause side effects like gastritis, gastric intolerance, and very rarely gastric bleeding. So of course, when somebody bleeds on aspirin, you want to make sure that there's no ulceration and all of that. So that needs to be sorted that way. But if you're having difficulty with aspirin, certainly, there are many other acute treatment options. So triptans are the specific acute treatment option for migraine attacks. Okay, and there's 7 different triptans. Okay, certainly, so you should try. Most GPs will start you on sumatriptan, because that's the most commonly used triptan, is the cheapest triptan. But there's 7 for a reason, right? So the most common problem that I see in practice is that people have tried 1 or 2 triptans, and then both the patients and the doctors have given up on triptans. Okay, but ideally, what should happen really is somebody to try and understand why that triptan does not work. For example, the sumatriptan tablet might not work if you get a lot of nausea. Okay? So then you might use a dispersible tablet that dissolves under your tongue, or you might want to use a nasal spray, or worst case scenario, you might want to use the sumatriptan injection, which bypasses the stomach essentially. So there are reasons why triptans don't work. Sometimes people's attacks are long, so they get infrequent attacks, but when they get the migraine attacks, it lasts for 1, 2, 3, 4 days. So you need a longer acting treatment like Preventative or naratriptan. Okay, and then yet again, some women will have migraines around their menstrual attacks, and again, Preventative is probably the best triptan for that particular attack. So there are different triptans, and they should be used. And if you don't respond to one, you should try it a few times. If you don't respond to one, you should try 2nd or 3rd, essentially. Okay, because it's possible, quite likely, that if you try 3 or 4 different options, one of them will suit you, and then you can sort of take that. Now, with the triptans, you can't use them every time you get a headache, because if you use it for more than 8 days in a month, you get more headaches.
Okay.
Yeah, so you should not use for more than 8 days in a month. But the triptans are there to treat the acute attack. The beta blocker, the propranolol you mentioned, is a preventive medication. It's something that you take every day regularly. It takes a few weeks to kick in, and the dose needs to be adjusted as long as you tolerate it. Some people need a higher dose, some people need a lower dose, and then it starts acting and preventing the migraine attacks. So the numbers should go down, and the intensity of the attack should go down as well. Okay, but that's not the only option. Again, there are many different options. So you've got amitriptyline, for example, similarly to propranolol, or candesartan, or topiramate, many things, flunarizine, and things like that. So, okay, but that's the preventive treatment. Then you got like.
Just ask that if you're not speaking that you mute, otherwise we get a lot of background noise. So yeah, that would be helpful. Sorry for that. Thank you, Dr. Maniyar. There was a question in the chat about the evidence around supplements, particularly magnesium and riboflavin.
Sure. So there is evidence, there is some evidence that riboflavin can be effective, and so as magnesium. In my understanding, the evidence is better amongst riboflavin, magnesium, and coenzyme Q10. It's better, the best rather, amongst the group for riboflavin. So that's my preferred natural supplement, but certainly completely right to use magnesium or coenzyme Q10 as well. The evidence is not very strong, and certainly that's clinical practice as well. So, you know, so if you are a migrainer having 3 or 4 migraine attacks every week, you know, very disabling attacks essentially, it's unlikely that just taking riboflavin is going to make a huge difference essentially. But if you are a migrainer who gets some mild attacks here and there, and then you might want to try that first really before you try some of the stronger treatment options. The advantage of the supplements is that the side effect profile is very good, right? So you don't get many side effects with the riboflavin except darkish urine. Magnesium very rarely can cause some diarrhea, but very rarely really. I've hardly seen any side effects with these natural supplements. So it's a bit of a balance between not so effective, but side effect profile is very good with the natural supplement. So if somebody wants to try it, by all means, it should be tried. The dose has to be correct though. So riboflavin has to be 400 milligrams, not the natural supplement, you know, not the mix that you get with multivitamin, which contains 40 or 50 milligrams. That wouldn't work. And again, magnesium, the evidence is there for about 500 milligrams. That's the best evidence for 500 milligrams. So again, the dose has to be correct.
Lovely, thank you. And Dawn, you had your hand up. Oh, I think I've just asked you to unmute. Oh. Has that worked?
Can you hear me?
I can, yes.
Good. I've unfortunately had hemiplegic continua for 21 years, and I take indomethacin with no problems. But 3 years ago, I got really stressed, and a purple dot appeared in the center of my vision. That eventually disappeared, but it's left me with blurry, scintillating scotoma in the center of my vision, which my neurologist has described as a migraine with aura. And I'm now taking a Jovi, but is there anything else you can recommend?
Okay, so my understanding is that you're taking indomethacin for hemiplegic continua, and that is working well for that?
Yes.
Good. So, but more recently you started migraine aura symptoms, is that right?
Yeah.
Yeah. So why have you been given HOV if the indomethacin is controlling the headache, or do you get additional migraines as well, is it?
I'm getting the migraines as well. Yeah.
Yeah, I see. So the hemiplegic continua obviously is one-sided fixed headache, right? The migraines obviously can change from side to side, and they come and go. So you're getting a lot of those, is that right?
Yeah, yeah.
I see. And you're on HOV for that?
Yeah, yeah. So I've just taken my first dose a few days ago.
Yeah. So, okay. So, see, HOV is, as you know, the flimazumab, which is the antibody against the CGRP molecule. So the HOV is obviously treatment for migraine. HOV is not a treatment for hemiplegia continua. So HOV is not likely to influence anything about the hemiplegia continua. But HOV can very successfully treat your migraine headaches, including the aura symptoms as well. Okay. Yeah. So what I suggest is that if you've taken one dose, the best effect of HOV starts after the second dose. Okay. So you have to wait. So once you get the second dose, that's when the real benefit starts. So we generally give 3 doses to people, and then we look at people at the end of the 3rd month to see whether something has worked or not. But really, what I tell patients is that they can really start expecting the best effect after the second month. Okay,
Right.
so yeah.
But do you think this problem in my eye is related to the migraine, or do you
Well,
think
I mean,
it's
that is,
related to
yeah.
hemiplegia?
No, you see, that's a very difficult thing to answer, Dawn, on here, right? Because you see, again, I mean, I'll have to consult you in details, but generally, migraine aura symptoms are episodic. They come and go. You know, if you get
This is 24/7, Miss.
Right. Okay. So 24/7. You've seen the opticians and the eye doctors.
Yeah, they all say it's neurological.
Okay, fine. So there is something called as persistent aura. So there's typically aura symptoms come and go, last maximum 1 hour. But there's something called as persistent aura. Okay. Now persistent aura, you know, can occur in migraine, but we need to make sure that nothing else has happened. Okay. So for persistent aura, personally, I would always recommend an MRI scan of your brain to make sure that you had that. So that's all good. Yeah.
Yeah,
that's all good. And the eye doctors are happy as well. That's fine. So in that case, you see, so in that case, it can be persistent migraine aura, which obviously is related to migraine, not hemiplegia continua. But now again, you may be one of those unlucky people who have had one headache problem, which is hemiplegia continua, but you're also now getting a lot of migraine attacks, essentially. Okay. Now again, it's difficult to say from here, but I mean, generally speaking, when I see people like that, and one has to question is, do you actually have hemiplegia continua? Or is it all just migraine? I cannot say that on video here. But assuming that you have hemiplegia continua, which is controlled with indomethacin, you now seem to be getting a lot of migraine symptoms, which is a different kind of a headache and this visual disturbance, which can be persistent aura. If you have started with HOV, I would just recommend to you that just stay with that, because potentially it can help your visual symptoms and the headache, but you might have to try 2 more doses for us to know, essentially.
Right, okay.
Okay?
Yeah.
Thank you.
Thank you.
You are
we've had a question around how to manage the neurological symptoms of migraine when people aren't getting the headache symptoms.
Yes. So, I mean, so the neurological symptoms of migraine without headache are, so you get migraine aura symptoms, so the typical visual disturbances which can come and go, sometimes sensory disturbances, tingling, numbness, starting on the face, traveling down, or starting in your feet, traveling up, and very rarely other things like, you know, weakness and symptoms like that. Now, the migraine aura symptoms are the best treatments in my experience for that. So if you're getting a lot of migraine aura symptoms without much headache, sometimes you can get the migraine aura without headache, but you get no headache at all, then those people respond very well to an anti-epileptic medication. And the favored medication in my experience is one called lamotrigine. That generally works very well and starts reducing the electrical disturbances that go with these migraine aura symptoms. So that's what I would do. Now, obviously, there are many other non-headache symptoms, right? So I saw somebody writing up about dizziness, you know, so there's something called vestibular migraine, where dizziness is a prominent symptom and that needs to be addressed properly. Again, you know, one can use the usual medications, but there's some other medications that can work well for the dizziness dominant migraine, if you like, or vestibular migraine. So I've used things like, you know, venlafaxine, lamotrigine in some patients, other than the usual medications. But also those people will need vestibular physiotherapy and other sort of aspects of treatment. So, you know, non-headache symptoms are many. One has to consider what context is the non-headache symptom or aura symptom, different kind of treatment. Is the non-headache symptom dizziness, which is vestibular migraine, it's a different symptom as well. And of course, there are other things, right? So light sensitivity and all of that. So, you know, one has to really, all of those things can be managed. It should be managed.
Dr. Maniyar, could you just adjust your camera slightly? Someone's saying they need to be able to see your lips when you're talking to see what you're saying.
Okay, sorry.
Yeah,
yes,
lovely. Thank you.
Is that better?
I think so. I can see you better now. So.
Okay, let me see how. Okay, I see what you mean. Yes, I think that might be better. Is that okay?
Yes. Yeah. Thumbs up. Lovely. Thank you. And Louise has her hand up.
Hi. Yes, I'm
Hi
Louise. I've got hemiplegic migraines, and it's like 4 days a week. I'm totally can't do anything. And my neurologist said, Dr Shah from Queen Elizabeth in Glasgow said that we've exhausted all options because of topiramate and amitriptyline. I had taken a rash on my stomach. I'm on Pitzacin and propanol, but I've been on the Pitzacin for years, and I think I've just got too used to them. But I've kind of gave up with neurology, and I haven't seen my neurologist for 7 years because my brain scan says there was nothing sinister going on. In December 2010, they thought I had a small bleed to the brain. So I'm 49 now, and I've been taking these bad migraines from the age of 31. They tried to put me on the Migraine injection with the EpiPen, but when I'm taking hemiplegic migraines, I can't stab myself with that EpiPen. So I feel as though that we've exhausted all options, and Dr Shah says, Louise, the only thing we can do for you now would be going forward getting injections, Botox injections every 3 months. So I've gave up.
Sure. Okay, Louise, thank you for the question. So I understand that you are having lots of migraine attacks. You said about 4 weeks. So that basically means you're having, certainly more than 15 days of migraine every month. So you basically classed as chronic migraine. Okay.
Yes.
And you basically, tried and failed many preventive medications. You mentioned topiramate and propranolol. You're currently taking pizotifen and one more amitriptyline currently. So you certainly tried more than 3 medications. So you are a candidate now for newer, not just newer, but additional treatment options. Okay. Now, certainly Botox can work. Botox, I've had a lot of success in Botox. It is done every 3 months, can be useful in reducing your migraine attacks. The good thing about Botox is that it doesn't cause any side effects like you may have experienced with topiramate and other medications, so wouldn't very unlikely to cause a rash. You mentioned a rash, very unlikely to cause any memory effects that can happen with topiramate, or drowsiness or sleepiness or tiredness, any of those symptoms. Okay. Botox can cause some local side effects, minimal local side effects, but generally they're tolerated very well. Now, there's another line of treatment that can be considered for people like you. I would say you've got very dissembling migraines and you've got refractory migraines because you're not responded to many lines of oral treatments, right? So you may have heard of this new treatment, the CGRP antibody injections. Okay. Now, you mentioned hemiplegic migraine. Those new medications, the CGRP medications, they have not been specifically studied in your kind of migraines, okay, the hemiplegic migraines, the complicated migraines. That's why one has to be aware that there's no direct evidence about how those injections will work for people like you. Now, if you ask my opinion, now this is an opinion, okay, I don't think people like you will, I think you should rather respond in a similar way, So if I quote some people 60% chance of improvement, I would quote a similar, with the newer CGRP injections, because fundamentally it's the same thing, right? It's migraine essentially we're dealing with. Although one has to be aware that it has not been specifically studied in your kind of migraine attacks. But if you've been offered Botox, I would certainly go ahead with it. Okay, you try 2 sessions. If they don't work, then I would certainly consider one of the CGRP antibody injections with understanding. When I say understanding, meaning you as a patient and the doctor who writes the prescription need to understand that the CGRP injections have not been specifically studied for this kind of migraine, but it appears and logically it seems that it should work equally well because it's still migraine. So that's what I would recommend. Yeah.
I'm open to trying new treatments, but I feel as though I just feel as though everybody's just gave up me because I've exhausted all the options, really, all the tablets.
But you haven't, Louise, you haven't exhausted, you only exhausted the tablets, right? I mean, well, not exhausted, but you tried 4. And, a lot of times these tablets don't work. So you're not the only one, really. There's sometimes or many times the tablets are not tolerated, so people can't take it because of side effects, really. Okay, but that should open up the door for other things like Botox, like the CGRP injections. Sometimes they do multiple cranial nerve block, or greater occipital nerve block. So all of those options should be made available to you.
My doctor told me when I take tablets, I've got a blockage in my stomach, and that's why the tablets just come up. So I found that when I'm taking sumatriptan, or I was told to take 2 paracetamol, 2 brufen, and a sumatriptan all at the same time. And then my doctor says, well, why don't you change it to 2 paracetamol and a sumatriptan, and then take the ibuprofen 2 hours after? And the tablets just been coming up with sick, and that's why they says the Migraine injections. But I'm terrified of injections, and I just couldn't do the EpiPen myself.
Yes, yeah. I mean, you see, that's right. You see, Louise, so using the is the sumatriptan injection during the attack is not so easy, especially if you're feeling a lot of nausea and sickness and you're not completely with it. It's not so easy, right? And I think if you're having a lot of these attacks, like you said, 3 or 4 attacks a week, really the emphasis at this point should be to try and prevent the migraines. Okay.
Yes, so that's why I'm on the pit.
Sorry, I think we're going to have to move on there, Louise, because lots of other people have got questions. I'm just mindful of the time. So,
okay. Thank you.
Yeah. Thank you.
Sorry, I muted myself, which is not helpful. Sorry, someone was asking what happens when someone's tried all possible preventive medications, but none of them have worked. And I suppose that just builds on a bit on what you were discussing with Louise there.
Yeah. So, you know, preventive medications, certainly if you've tried 3 preventive medications, you become eligible for other things in on the NHS. So the Botox injections that we talked about, we talked about the CGRP antibody injections as well. Okay. But again, within those tablets, there are different kinds of tablets, right? So one has to talk a little bit about that. You know, so for example, topiramate is a very strong anti-migraine preventive medication. So if you haven't tried that, if you don't have any contraindications like kidney stones or increased pressure in your eye socket, glaucoma, then certainly you should try that. You know, the chances, well, there's a 40% chance you'll come off it because of side effects. But if you don't come off it and you're lucky not to get the side effects, there's a high chance you feel better. So depends on which ones you've tried. And again, depending on your kind of migraines, you've got vestibular migraine, then I certainly would try venlafaxine. In my experience, it works well. So, you know, so there's a caveat there. But if you've tried many, certainly, you know, as far as the rule of the NHS is concerned, is 3 preventive medications. And after that, you can get Botox as well as the CGRP antibody injection. You should be able to get that.
Lovely, thank you, Dr. Maniyar. And I don't know what your name is, but you're down as Abbott. So.
Hi, my name's Sam. I guess what I was thinking about is I've had migraines since my early teens, and there's very much been a correlation with hormones. I'm now through the menopause, and my migraines have increased dramatically. I've been through all the preventatives. I use triptans. I use them too much, more than you suggest. I have Botox, which was effective initially, but the effectiveness is certainly reduced. And I'm just wondering, I guess, more about what research really is being done into the links between hormones and particularly things like the menopause, but also what next for me, because I'm really aware, particularly with the triptans, I use more frequently than I should. But without it, I can't function. I wouldn't be able to go to work. I wouldn't be able to do things. I have migraines 4 or 5 times a week. And I always feel when I go and see a doctor and they say we're using too much, like, well, what do I do? What else is there?
Yeah, no, thank you for your question. So as far as the link between menopause and migraine is concerned, there's definitely a link there, of course, right? But it's not as simple as, for example, you know, you can't just have a blood test and check the levels of your hormones, you know, which one is low, which one is high. The one that is low, let's replace that, and then it'll all be fine. It's not as simple as that. It's very complicated, essentially. Of course, when you're going to the menopause, your hormones levels change, but there are other things that can change as well, you know, so the adaptive mechanisms and the areas that are involved in migraine, their function might be different at the time of menopause. Because what we've seen is that, you know, so women, for example, when they're going to the menopause, obviously, when they go on HRT obviously tries to increase the level of estrogen, which is low when you're going to the menopause. That doesn't necessarily have a big or a lasting effect on the migraine, certainly in my experience. Okay, so
Yeah, I can't take HRT anyway because I've got risk factor for blood clots, so I can't take it.
But yeah, I don't think you're losing much there because even if you take HRT, I don't think it makes a big difference initially. Okay, so we almost have to. It's a little bit of a. We almost have to dissociate ourselves to the fact that actually we recognize that you're going to the menopause, and we recognize that you're having a lot of migraines around this time when you're going to the menopause. But the answer is not hormones, if you see what I mean. Okay, the answer is not hormones. Now, just to give a natural history, many women after they've gone through the menopause, well established after the menopause, migraines will generally reduce. Not all of them. I've got many women in their 60s, still having migraines, but to a lot of them it can go down. Now you're having 4 or 5 a week. Again, you will be classed as chronic migraine. Again, on the NHS, you've got different medications one could try, and then you've got the preventive medications, and then of course the preventive medications don't work, then you've got Botox and the CGRP injections one could try as well. Now the question comes to medication overuse, meaning if you have been taking a triptan, for example, for more than 10 days in a month, then you'll be cast as medication over, somebody who overuses medications or medication overuse headache. And you see a lot of times people will want you to reduce that intake before they give Botox to you or the CGRP injections. Okay. Now, this is a bit of a gray area, really. I mean, certainly it's good advice to patients, but I mean, I understand what you're saying in the sense that you take the triptans because you have to take them, right? Now, it is true that if you take triptans very often, it will also cause headache in its own right. But my experience, that is true, but it's not. I don't think that's a very common scenario. Number one. Number two, even if you take the CGRP injections or the Botox, when you have been using more than 10 days, let's say you've been using 30 days of triptans every month, it's not that the Botox is not going to work or the CGRP will not work. Research has shown that they will still work. Okay, sometimes as well as irrespective of how many days. So generally, I'm a bit lenient to my patients. So, I tell them that you should not be using for more than 10 days. But they show me a diary where they show is 12 days in a month. I don't send them back. Yeah, because I believe that the Botox is still going to work. And once the Botox reduces the amount of migraines they're getting, then they will take less and less triptans, right? So that's a better way, I guess, of dealing with the situation.
I guess my dilemma is I have Botox and I have it regular every 3 months. And initially it was very effective. The first dose was like amazing. And since then it can vary each time. And now my number of migraines is the same as it used to be, and it's worse, but it's the severity of them is probably less. And the effectiveness of the triptans is greater. But I'm still stuck with that number of migraines. And do I push to try something else?
I think so. You should. I think you should now move on from Botox to another treatment. So CGRP, for example, one of the CGRP injections, because they're very different. They're very, very different kinds of medications. And what we're really seeking, really, the goal is to help you much more than what is happening now, essentially. See, so we can't cure the condition, of course, we accept that. Even the newer injections work very well. We can't say it's cured you. But, if you're still having as many migraines as before, you said 4 to 5 a week, I think that's not sufficient then, you see. I think we need to change the treatment line to a CGRP antibody and see whether that gives you a better benefit.
Okay, thank you very much.
You're welcome.
Dr. Maniyar, we've had a couple of questions around diet, particularly low carbohydrate diets and different types of diet and research around those. If you could expand on that a little bit, please.
Yeah. As far as diet is concerned, really, what I tell patients is very simple. This might sound very simplistic. I just tell patients that you should avoid dehydration, have regular meals, avoid too many abrupt changes in glucose levels. So not eating breakfast, not eating lunch, and having a heavy dinner. So the glucose levels go down and then up, and that's not good for migraine patients. So smaller meals throughout the day, so constant glucose level, lots of hydration, avoid dehydration, particularly when you drink alcohol, things like that. So that's what I say about diet, essentially. I don't think there's any strong evidence that any particular kind of a diet is better in migraine than others, essentially. And there's no convincing evidence about any particular dietary element. I saw thiamine mentioned, coffee, of course. I mean, of course, overuse of coffee is not good. Certainly, there's some suggestion, some evidence there. So I say maximum 2 cups in a day. But other than that, it's not that you are allergic to a dietary element or a particular kind of a diet is not right for you, and that's the reason you've been getting migraines. And so I avoid, actually, I discourage people from spending a lot of time and money in doing this allergic test and things like that to find the one element essentially. Now, rarely you come across somebody, who tells you that, listen, my doctor, you're saying all of this, but in the last year, I had 4 migraines, and each one of those migraines happened when I ate, when I ate my favorite Chinese or something like that, essentially. Then one has to, consider, well, is there something in there that is acting as a trigger? But that's not a common scenario, really, because if you really ask that person, are you sure you had only 4? Are you sure you didn't have any of these attacks when other times and you didn't eat Chinese or that particular food item that you're referring to? And the answer invariably is yes, they have been having headaches here and there as well. So really, it's a very simplistic message from me: regular meals, steady glucose levels, lots of hydration, not so much tea or coffee, caffeine in other forms as well, not very good. And that's it really.
Lovely, thank you. Richard, your hand was up.
I think he's muted.
Oh, hang on.
That's it. Right. Good, thank you. I've been content to listen. Mine is a long story, and it's interesting hearing the different sorts of migraine that various people have had. Now, I first came across it 60 or so years ago and diagnosed it myself. I was a dental student at the time. Oh, yeah, yes, heard about that. And that was really an aura followed by a headache. And I had quite a lot of that. And as things progressed, I began to get what I believe is now called hemiplegic migraine, which was a range of symptoms starting with an aura, and then there would be numbness in my right hand moving up. And once it got to about this level here, speech began to be affected. And that continued for quite some time. And then it finished up with a splitting headache. And this would last for maybe 1.5 days. And I just, as I said, I was in dental practice. I just had to close the doors and leave it to a colleague. Now, the interesting thing is that changed. And I had heard as people get older that this migraine should be less. And as I reached my upper 70s, that was very much the case. I was having more frequent attacks of migraine, but not a great problem. And the trigger, obviously I'd tried all the possible exclusions in the course of my life. The trigger for me currently is a flash of light. I've always had that, but that's the main thing. The front of our house, for example, has a road curving.
Hey, Richard, can I just ask that if there is a question for Dr. Maniyar, we go straight to the question, just because there's a lot of questions coming in. Sorry.
That's fine. So it is a long story. So so I was quite coping with that, and then a couple of months ago, I didn't know what was happening to me. My wife thought I was having a stroke. I just didn't really know where I was. I could not speak at all. And we dialed 999, which unfortunately was not, there's nobody there kind of thing. But my wife did get this differential diagnosis of ruling out a stroke. Now, I don't know where to go from there. That's the bottom line.
Oh, so sorry, Richard. So you've been diagnosed with a stroke? Is that what you said?
No.
No.
No. Well, actually, the nearest I got was the people in the ambulance service.
Oh yeah.
Who did a telephone diagnosis. I could hear him, and when I was asked to raise my arms, usual routine, I did that.
Mm-hmm. And your symptoms were typical. You know, the symptoms that you had this time were typical to what you get with your migraines. Was it different?
I had never had that before. It was quite terrifying.
So what actually happened? So you didn't tell me what happened this time.
Right. Okay. I was sitting in a chair, and I felt I couldn't be motivated to move. The wife tried to get me to bed, and I was staggering and hallucinating slightly. When she got to the bedroom, I couldn't work out which was the bathroom, which was the bedroom. I was so confused as that. I was trying to tell her to phone a neighbour, phone 999, which she went ahead and did anyway.
What sort of hallucinations were there, Richard? What sort of hallucinations?
I felt, funnily enough, I felt as though I had almost what do you use for a pumpkin? I felt as though my head was as useful as a pumpkin, because I couldn't speak. I could see all right.
Yeah. Yeah, no, I think, yes, sir. Thank you, Richard. So obviously your symptoms, what you described now, they're very different from your typical migraine attacks. So one cannot really say this is migraine. This needs to be properly assessed, really. Obviously, you know, there are many things that can cause a problem like yours. I think what you need to discuss with your GP and get a referral to a neurologist. Okay, because somebody needs to see you, assess you. You will most likely need an MRI brain scan to make sure that nothing newly has happened to cause these symptoms. Okay, so these symptoms obviously don't sound typical for a migraine attack, not even a hemiplegic migraine attack. Now, having said that, you know, I mean, having seen patients with migraine for the last 25 years, one has come across all kinds of things. Okay, but it will be rather silly for me or anybody to say, oh, Richard has been having a lot of these complicated migraines. This must be another of his complicated migraines. One cannot say that, really. This needs to be assessed properly. You need a new scan, a fresh scan, to make sure nothing new has happened. Obviously, I can't tell you right now, you know, just listening to a few sentences about what exactly this is, but it's suffice to say this is different from your usual migraine attacks and needs to be investigated. I think you will need an MRI brain scan and actually see a neurologist.
Yes, well, that's right. The online consultation is really a complete waste of time.
Yeah, no, yeah.
Right. It is very difficult to we all know that, difficult to get a proper consultation.
Yeah.
Thank you, Richard. Thank you, Dr.
Maniyar. Thank you very much. Thank you. Very helpful.
Thank you.
We've had a couple of questions around sort of stomach pain, stomach problems, and IBS related to migraine.
Yeah. So yes, stomach pain is abdominal symptoms are common in migraine. So for example, if you look at the evidence of how often babies with colicky babies, so children with lots of abdominal pain, when they grow up into adulthood, a lot of them will get migraine essentially. And during migraines, a lot of people will get stomach symptoms like nausea, sickness, tummy pain, sometimes frank diarrhea and constipation as well. That's one story. The second story is that migraine attacks may not necessarily cause a lot of tummy symptoms during the attack, but hand in hand, essentially, those people also have IBS. Essentially, now IBS and migraine are comorbid. So if you've got migraine, you're more likely to get IBS, and vice versa, essentially as well. So they can come together. Now, generally, you see, again, the practical utility of that information is that one has to be aware of the situation that a particular person might feel extremely nauseous and get a lot of tummy problems when they're actually having the migraine attacks. So therefore, you know, one can't just rely on tablets to be absorbed. You have to give some oral dispersible tablets, nasal sprays or injections, essentially. So that's the practical utility of that information. And then a lot of those symptoms can improve essentially with migraine preventive treatment. So when the migraines get less frequent and less troublesome, a lot of those tummy symptoms can get better. Not always, because if you've got separate IBS, then that might need treatment in its own right, of course, right? So you might have to see a gastroenterologist, make those dietary changes, take, you know, IBS can be diarrhea dominant, so you have to have anti-diarrhea tablets, or IBS can be constipation dominant, so you have to have good treatment for constipation and dietary regime for that. So that needs to be looked into separately as well. But migraine can also be associated with a lot of tummy symptoms which can be looked into. Now, the last thing I would say on that is you will come with, I will see these patients rarely where they get this severe tummy pain, episodes of tummy pain, and they've seen gastroenterologists after gastroenterologists, they have done the endoscopies and all of that, and there's nothing wrong with their gut essentially. Okay. And very rarely, now this is rare, of course, now very rarely those patients will respond to anti-migraine tablets. So whether the manifestation in those people is tummy pain rather than head pain with migraine. Okay, so that's not common, but that is another thing that I have come across in some people.
Lovely, thank you, Dr. Maniyar. Lorraine.
Thanks, Gemma. Just a quick question really in regards to the medication I've just been prescribed by a neurologist. I've tried propranolol, amitriptyline, topiramate, have some Aspirin just as an acute dosage now, but she put me on Candace, have I said that right?
Yeah.
But then when I've looked it up, it's for high blood pressure, but I suffer from low blood pressure. So that just concerns me in that, is that going to cause me problems?
Sure.
That I can't really.
Yeah, good question. So, Lorraine, so Candace is true. Candace is a tablet for high blood pressure. Okay, but it's got, so Candace acts on an enzyme which is involved in blood pressure regulation. The same enzyme is also involved in pain pathways. Okay, so that's why Candace can be useful for particularly migraines, okay, not just any pain, but just migraine. And now it can have an effect on your blood pressure. In your case, what I would recommend is that you start very low, like 2 milligrams, and slowly build it up by 2 milligrams every few weeks. So your body gets a lot, higher chance, a longer chance to get used to the medication. You see, Candace in your case now is obviously the levels might go down, blood pressure levels might fall down by a few units, but that doesn't necessarily mean that that process will create symptoms. Okay, a lot of times people get obsessed with blood pressure. They check their blood pressure before and then after. Oh my God, my blood pressure has gone down from 130 to 110. That's fine. Okay, as long as you're not fainting out, so when you stand up quickly, you're not losing your vision, you're not passing out. As long as that's not been happening, as long as you're producing enough amounts of urine, that means your kidneys are getting flushed and all of that, then that's fine. So just numerical drop in blood pressure is not necessarily a cause of concern. Okay, and if you start on a low dose and build up slowly, you're more likely to benefit from it, essentially. And it's one of the better medications, really, and the good thing is that side effects are less common with Candace compared to, in my experience, the amitriptyline and the topiramate. So I would certainly give it a try.
Okay, thanks. I think it's the last medication she wants me to try before I can then go on to the CGRP, the injections, yes, the HOV injections and things like that. So I just wanted to check that was the right thing, but thank you.
You're welcome.
Thank you, Dr. Maniyar. There are a couple of questions around neck pain in migraine and the potential role of a chiropractor.
Very good. Actually, thank you for raising that up. That is really, really useful. Neck pain is extremely common in migraine, extremely common. I'll tell you of the common scenario. Neck pain, again, we did a lot of research on this, and when I looked at my patients, neck pain was one of the most common first symptom, right? So if I ask 100 people, how does your migraine start? The migraine starts here, there, this, that, and all. Okay, but then we see what is the one symptom that comes again and again and again. It's one thing, that's neck pain. Often starts in the neck. Now, what happens is people say, oh, I woke up in the morning, I didn't sleep right, my pillow was not right, I had a sprain in the neck in the morning, and that led to a migraine attack in the evening. I don't think that's a common scenario. The situation is that your migraine started in the morning when you woke up, when you had the neck pain. That was the start of the migraine. Because you have been using the same pillow before that as well. And obviously, we all sleep slightly differently on every night. Nobody sleeps exactly the same way. Right? So what has happened is that the migraine has started in the morning when the neck pain has started, and then obviously over the headache later on in the day. Headache is not the only symptom of migraine. You can get symptoms, we call them premonitory symptoms. So we use premonitory because it's a premonition that a migraine headache is going to come. And again, neck pain is one of the most common signs, indicators, or warnings that a migraine headache is to follow. And that can happen up to 3 days, really, but more commonly, certainly a few hours, really. So neck pain, a few hours later, the headache, essentially. Now, the importance is that doesn't mean there's a problem in your neck. Okay, the neck pain is caused by migraine. It's not that somebody's done an X-ray and it's shown there's dehydration or the spine is not exactly aligned properly. That's not the reason why you're getting the migraines. Okay. Now, when you go to osteopath and chiropractor or physiotherapist, what I would say is, as long as they're not doing anything heroic with you, that's fine. Because once that happens, you can get secondary muscle spasm. So if somebody does a soft massage on your neck, make sure to sit right and all of that. That's good advice. That's not bad advice. That's going to help you to some extent. But that doesn't prove that the problem is in the neck. So as long as all these therapists are doing some soft, benign things with you, like massage and posture correction, I'm okay with that. But don't fall prey to the theory that, see, you get neck pain and that leads to migraine. In my experience, that is not the common scenario. That's not the common truth. Yeah. So, and therefore, just utilizing your neck will not be the right. Just having osteopathy wouldn't be the right thing. Helen, can you just give me 1 minute? I just need to go to the door. Sorry, somebody is desperate to come in. Just give me 1 minute, please, if that's okay.
Okay.
Thank you.
Whilst Dr. Maniyar's nipping to the door quickly, I will just say that unfortunately we can't take the questions from the chat and answer everyone directly outside of this, but you can contact the Migraine Trust helpline with any questions and we will get back to you with a detailed response. The contact details are in the chat and Helen will pop them in again. There is lots of information on our website as well, so do please have a look at that if you haven't already, to try and get some answers to your questions. But do contact our helpline because that's what we're there for, to answer questions. So if Helen can pop those in the chat, that would be super helpful so everyone's got them. I know that there's been lots of questions and I'm very sorry we haven't had time to get through all of them, but I hope this has been helpful for everyone who's attended. It is recorded if you did want to watch it back, and so we shall just hopefully Dr. Maniyar will be back in a moment and we will send the recording round to everyone, so that will be sent out afterwards. Yes, so I'm just having a quick look through to see if there's anything that I can try and answer quickly. So I think someone's asked us if there's DNA research happening into migraine. Not that we're aware of. If you are interested in research into migraine, the NIHR, so the National Institute for Health Research, have a website called Be Part of Research, and you can search via migraine on that, and you can look for searches that are coming up. But Dr. Maniyar's back, so I will stop talking. Alicia, your hand's been up for a while.
Hello, yes. Thank you for doing this. Really appreciate your time. I really briefly, I'm 26 years old and the past 20 months I've been suffering with dizziness, vertigo, dissociation. The symptoms have been getting worse and more severe. So added on tinnitus, ear pressure, brain fog, and then I started developing headaches that aren't it's severe, but are there for a couple of hours, like very, very occasionally, and slight light sensitivity. So I was diagnosed originally with Meniere's disease, and that's now been changed to vestibular migraines. So all of my treatment plans changed. They tried me on amitriptyline and I reacted really badly to it. So they told me to come off that and they've put me on sertraline now, which seems to have calmed the dizziness down slightly. My vestibular rehabilitation therapist also diagnosed 3PD as well. So I think the sertraline's helping with that side of it. My question is, firstly, how confident can I be in a vestibular migraine diagnosis? Because it's causing a bit of anxiety that it's not a typical migraine and I don't want to try all these medications if it's not. And secondly, what treatment options are available for that, as my GP now won't give me anything because they said it needs to go to a migraine specialist. My ENT who diagnosed me with vestibular migraines also won't give me anything because he said I need to speak to a neurologist, and neurology have a massive waiting list, and all of my appointments prior to this I've paid private for because I've been waiting 20 months and not being able to get anywhere and being off work. So it's massively impacting my life now. Just a bit of advice.
Sure. Thank you, Alicia, for those questions. So vestibular migraine, of course, is a condition where you get dizziness, of course, as the name implies. Yeah, but the cause of that dizziness is migraine. So typically you get a lot of dizziness, but also headaches and light sensitivity and sound sensitivity. Okay, you may have had migraine aura symptoms, zigzag line, and visual disturbances. Not all of them. Some people will get that as well. Okay, I guess not in your case.
No.
But again, I mean, obviously, I'm assuming that all of that is correct, and it's likely to be correct. Vestibular migraine is a far more common problem than Meniere's disease. So, say 20 years down the line, 20 years ago, essentially, rather 25 years ago, a lot of those patients who had a diagnosis of Meniere's disease, we're now finding that actually it was never Meniere's disease. Okay. And is actually vestibular migraines, because migraines are much more common problem, right? So 20% population has got migraines. Some people of them will develop vestibular migraine, and that percentage proportion is still much higher than Meniere's disease, the population of Meniere's disease. Okay, now that's number one. Number two, I see a lot of patients with vestibular migraine who also have anxiety. Okay, it's almost that the dizziness and the anxiety, they go hand in hand. Essentially, something about that. Okay, so that doesn't necessarily mean that you are, you already. Of course, people can have two problems, vestibular migraine and anxiety, but I see a lot of anxiety in patients with vestibular migraine, so the dizziness and anxiety go hand in hand, okay? The second thing. Now, as far as treatment is concerned, you're trying amitriptyline. Sertraline is an antidepressant and an anti-anxiolytic agent. It doesn't have a specific action on the vestibular migraine part, okay?
Yeah.
It can reduce your anxiety, and therefore you might feel better, but there's no evidence that it's going to act on the migraine pathway. Okay.
Yeah.
So one way forward would be to take sertraline if it's suiting you and helping you, but also try something else like propranolol for the migraine part. Okay. The second option would be to replace the sertraline with a tablet called venlafaxine, which is a different medication from sertraline. It's an SNRI kind of an antidepressant, but it's got a separate action on migraine as well. And I've had a lot of success with that essentially. Okay. So venlafaxine, this is a single remedy. Or you can have sertraline for the anxiety, but add on propranolol as well. And then continue with the vestibular rehabilitation. That's very important as well.
Yeah, that's really helpful. Thank you for that.
You're welcome. You're welcome.
I'm just mindful of the time, and I think we're probably going to have to wrap it up. There was another question generally that ties into that, I think, around anxiety and migraine in general. So I don't know if you've got any thoughts just more generally on that, Dr. Maniyar.
Yes. Again, you see, I mean, anxiety and depression and mood problems are comorbid with migraine. So there certainly can be an entity of having anxiety and depression and having migraine. But I think as patients and as doctors who are dealing with the problem, we should also be aware of the fact that having bad migraine attacks is not a pleasurable thing. Having bad migraine attacks, losing out on your life is going to make you feel low, right? If you don't have any control over your attacks and you can't be sure and confident, you're going to feel anxious about making arrangements, making plans with your family and friends. So that aspect needs to be understood. So vestibular migraine we just talked about, the dizziness doesn't make you feel confident, you become an anxious person. So there's a lot of that in my opinion, essentially, right? So in those cases, just with the migraine, that's the elephant in the room, right? Treat the migraine. If the migraine symptoms go away, patients will not feel anxious. That's the commoner group. And then there's a smaller group where there is migraine, but there's also anxiety and depression. There is, childhood history, and there's other pathological adaptive mechanisms and a separate diagnosis of anxiety and depression. And that needs to be dealt with, obviously, with the migraine as well. So there are two different kinds of scenarios there.
Lovely. Thank you very much, Dr. Maniyar, and thank you very much for your time today and for answering as many questions as you did. I found it hugely helpful. I hope other people have as well. As I've already said, you can contact the Migraine Trust helpline. There's a link in the chat box to the information on the website, and also the phone number and the email address. Thank you all for coming along and sparing your lunchtime. We will be sending the recording out so you can come back to it and see if there are questions you want to revisit. But all that's left to do is to say a massive thank you to Dr. Maniyar and to you all for attending, and we hope that you found it useful. But yes, thank you very much, everyone.
Thank you very much, everyone. Thank you, everyone. Thank you.
Thank you very much.
Thank you. Bye-bye.
Bye.
Bye.
Thank you.